You're watching Supporting Your Registrar to Manage the Challenging Patient, Part 1, produced by GP Supervision Australia and presented by Dr. Tim Chappell and Dr. Simon Morgan. We would like to begin by acknowledging the traditional custodians of the land on which this recording was produced and pay our respects to their elders past, present, future and their families.
Hi everyone, welcome. I think this is such an important area for registrar support. So we decided that we'd have two parts. Part one, more around information exchange and a bit of a schema from Tim's experience and a little bit of background theory. And then next we'll be talking more around strategies. My name's Simon Morgan. I'm a GP here in Newcastle and I'm on Awabakal country. And it is a great pleasure to introduce Tim Chappell, who's many of you will know as a Supervisor, GP and Supervisor Liaison Officer, SLO, from Western Australia, to join us tonight. I'll allow Tim to introduce himself a little more fully in a second. Interesting, we had a bit of a yarn, didn't we, Tim, about the best word and perhaps more palatable or politically reasonable is to use the word challenging patient, but often you will see the term difficult patient. In many respects, these patients are challenging and certainly can become difficult, and certainly difficult for the registrars about whom we're talking. The learning objectives are these. So talking about the background factors, so why are patients challenging? Talking to a framework Tim's developed around challenging patients. So Tim, thank you very, very much for joining us.
Thanks, Simon. I really appreciate it. In fact, it was when I first gave this talk, I've given it many times to registrars and I've tweaked it quite a bit for the seminar. But when I first did it, the powers that be, as you said, I called it dealing with difficult patients, and they didn't like that. But it's interesting, it's only people who don't practice general practice who say that. Those who practice general practice I've found, but maybe some people out there disagree. Anyway, we've changed it to challenging, and that is a little bit less pejorative, I agree. It's just about me. I was born in Perth, raised in Perth, went to UWA, and bummed around the hospital for a couple of years until I kind of acquiesced to my own personality and realised that I was a natural general practitioner. Then went up to work in Dampier, in the northwest town of Dampier, for 4 years as a country GP. Then came back to Perth, and for the last 23 years I've been at Fulham General Practice in Cloverdale. And all during that time, I've been teaching medical students, and when we were able to, when Fulham GP got the rooms, we had some extra rooms put on, we could have registrars. So since 2009, I've been having registrars all that time. And I love it. I love teaching. I love the practice of medicine, and I really enjoy the whole process. So my aims here are to classify the three different types of challenging patients. I don't want to go through what I think is a helpful category of the three different types of challenging patients. And then I want to use the 10 RSCGP attributes of a supervisor as a guide to discuss various things the supervisors can address. The next, I hope to outline specific strategies of the various different patient types. That's why the categories are important, because there's different strategies for the different subtypes of challenging patients. Right, we're going to start off with this quote. You can please some of the people all the time and all the people some of the time, but you can't please all the people all of the time. Abraham Lincoln, at least attributed to Abraham Lincoln. He actually said you can fool some of the people some of the time, all of the people some of the time, but you can't fool all the people all of the time. But it's come down in history as please. When I say this to registrars, they do all agree. Everyone agrees and nods about that. But internally, I suspect that many of us, and I certainly did this, many of the registrars, think, but I might be able to achieve it. I might be able to achieve it, particularly when they're watching you as the supervisor, because what they see is many times that challenging situations, challenging patients, they observe you, the supervisor, and you seem to do it smoothly. Things that you just take for granted, things that you think, oh yeah, don't worry about that, we do this, blah, blah, blah. And they think, that's just amazing. If only I knew more. So they think, I don't know enough, and that will help me through if I just know more. What I mean by that is more classical medicine, how to treat asthma, how to manage chronic diseases such as diabetes. If I know more about that, then I'll have less challenging patients. And the other aspect they may be thinking, apart from I don't know enough, is all you need is love. I put down from the Beatles, but what I mean by that is if I have the right attitude, if I know enough, and if I am caring enough and have the right attitude, then I will not only avoid being sued, but I'll be able to avoid the misery of the super challenging patient. Now, we all know that that is a fallacy, but that is what many registrars pursue. In part, they're half right, because you do need those things as a foundation. You can't go anywhere if you don't know your stuff. But what I want to show is how to build on that, because what we're talking about is people management, of which most registrars that I experienced who come from the hospital have had zero experience in that. And it can take them a long time to wake up to the fact that if they knew a few things about people management, then their lives would be a lot easier.
And just on that, Tim, it's an interesting concept, this notion of perceived competence, but also how much we want patients to like us. And there's a wonderful 2x2 chart that I remember coming across, which I often share with registrars. It is very much this sense of patients. They may respect our competence, but actually not particularly like us or feel affection towards us, particularly if we're not meeting their needs. But if they respect us as competent practitioners, then we're doing a good job. And it's certainly not enough to be liked if we're not competent. So I think that differentiation is really important to make with registrars.
Yes. And later on, we can see that some patients use that desire to be liked as a weapon, which can be very powerful for some individuals. So I just want to make a caveat for GPT-1 registrars, which is a slightly different category, because for GPT-1 registrars, really all patients are challenging patients. And as supervisors who are a bit long in the tooth, we can forget how that is for them. Many of them, not all, but many of them have come from a hospital situation where they are the dog's body. They just follow the team around with their notepad. They don't make any decisions at all. They're not really responsible for any decisions about the patient at all. And then suddenly they're thrown into a room and it's just them and the patient. And even when there's things that we think are just painfully easy, for a GPT-1 registrar, it is very challenging. For example, when someone comes in to a patient just asking for I just need a script for the oral contraceptive pill, I've had registrars who think, can I do that? Is that allowed? They're at that level. So every patient is a challenging patient. The learning curve is very rapid for most GPT-1 registrars, and they really progress beautifully and really well from that. But they do find it harder to identify who is a challenging patient and who is not. And they can be lulled into quite difficult situations when some of the challenging patients who have borderline tendencies or personality disorders can actually lull them into a very difficult situation. And they can be completely unaware that they're setting themselves up for it. Would you agree, Simon?
Absolutely. And I think that speaks to the importance of this topic, because without this conversation happening, very quickly our registrars can find themselves, managing many challenging patients and potentially manage them with difficulty and struggling. Tim, one of your strategies that we'll talk about is that sort of preemptive conversation, and people might say whether they actually do have these preemptive discussions. Is it something that they say, you may well encounter a bunch of difficult, challenging patients, let's have a yarn about what they might look like?
Someone said life experience is very helpful. It is very helpful indeed. But we can kind of accelerate that process, I think. So back to basics. What type of patients I'm referring to, I don't think we need to dwell on this too much. We're talking about those sort of patients, the ones that you see on the list and you think, oh, it was such a happy day and now it's all going to be ruined. Those heart sink patients, those patients where you just feel like you're going upstairs working the whole time. Nothing is easy and they don't give anything back. So we're just climbing the stairs constantly going up and nothing is easy. It's a Dementor from the Harry Potter films. J.K. Rowling created this brilliant creation of a Dementor, which is a creature that when it gets close to you, sucks out all the energy and joy from your life. And I don't mean this in any pejorative term. It's just a fact that some patients do that to doctors. They just do. And sometimes they're totally unaware that they are being a Dementor. But afterwards, the treatment for a Dementor is to eat some chocolate afterwards, GPs either need chocolate or, if it was allowed, I'd have a whiskey or something like that. When I first gave this talk, I put this picture up as a joke. I'd go through the slides I've just shown you, the heart sink, the Dementor, and then put this up of King Kong. And I thought everyone was going to laugh. I thought all the registrars were going to laugh. But when I put it up, I had a room full of 30 registrars, completely silent. You could hear a pin drop with this slide. And when I first gave this talk, I thought, I think I could be onto something here. I think this could be a topic that we should be talking about, because I meant it as a joke, but they took it absolutely seriously.
I like to, refer to the literature where it's relevant, because what Tim will be speaking to tonight is very much, I think, a distillation of his experience and reading. But I just wanted to draw your attention to this fascinating paper with what many may regard as a fairly pejorative title, published in 1978, so quite old now, about taking care of the hateful patient. And if anyone hasn't read this, I'd encourage you to. The terms that this particular practitioner used, the 4 stereotypes, as you can see there, were the dependent clingers, the entitled demanders, the manipulative help rejectors, and the self-destructive deniers. And again, you might think they're fairly unfair terms, but I presume most of us will have experience of that type of patient. And again, this is an interesting paper to read. There's sort of been a revisitation of this classification about 20 years later. And what Tim will be referring to, I think, is probably a more contemporary and a more practical classification that you may be able to share with registrars. But just to say that this is a good paper to read, and maybe even one that you get a registrar to read, and then talk through some of this stuff, again, respectfully, but in a sense describing these types of patients. The other thing that I think is important to highlight is we do a lot of work around managing challenging encounters, the angry patient, saying no to people, breaking bad news, those sort of scenarios that may crop up in patients who, have had a particular experience. But I think possibly that's been a little bit neglectful in my experience as an educator of managing patients that have more a pattern of behaviour over time, these patients that registrars and ourselves will see over and over. So I'm really happy that we're certainly addressing this.
Definitely. I think this article is a really great article. Fascinating. It was written in 1978, so the language is of 1978. I don't think anyone would call patients a hateful patient anymore, but taking care of the hateful patient. But it's a really good article, I think.
And Tim, it might be just challenging patient perhaps just labels the patient and blames the patient. And I do think that's an important distinction to make, that obviously a challenging encounter or a challenging patient is an interaction between two people. So I know you'll be talking that along the way.
I can preempt that by saying, absolutely. I think what I hope to show is that to people to have confidence that it's a difficult consultation and it's possible to be managed. I just want to reiterate of what Simon made allusion to. This is just coming from my own personal experience. I don't consider myself a kind of world expert in this area. Just watching patients and watching them with registrars particularly. That's where this is coming from my own experience. So let's get on to these classifications. So I've got the 3 types of challenging patients that I've noted. So the first type, the patient, inverted commas, has a normal personality who has an ongoing problem and symptom, and there is no clear diagnosis and no one really knows what to do about it. So this is surprisingly more common than many junior doctors realize, that these are the people, the lovely people, and they have an ongoing headache or vertigo or weakness or nausea or some ongoing problem, and they don't appear in any way to have a psychiatric illness. They just have the symptom. They've seen a specialist, they've seen another specialist, they've seen a third specialist, and they're unsatisfied with the view from the specialist. The specialist might be right or might be wrong, but they've come back to you to help you with their symptom. I think in this category, I also include people with ongoing, very challenging situations. not much to do with their personality. I include people with, say, with head injuries or acquired brain injuries, behavioural disturbances from any age. So the parents are coming in time and time again, or the carers are coming in asking you to manage this very difficult problem where everyone's on board. Everyone's on board who are caring for the individual concerned, and they're looking to you to help, but nothing is actually working. That's the first category of patient. Well, I just call them patient one. Patient two is probably more along the lines of the New England Journal of Medicine article. They have a difficult personality, I call it that way. Maybe a personality disorder, but maybe just personality disorder traits. And they come in with or without a problem or a symptom. And everyone knows what should be done. So this is the opposite of patient one, where no one knows what to do. In this one, everyone knows what should be done. But everyone knows what should be done, but the patient's not doing it. So that's basically it. So these are people who can really drain the doctor in a different sort of way, because I include people in this as drug seekers, people who are wanting to get something out of you without wanting to tell you. They wanted to get you to sign a form. They wanted you to sign off on something that you don't think is right, that you think this is the way we should go. Everyone thinks we should go this way, but the patient says, no, we should be going this way. And they keep coming back to see you, or they try and intimidate in some way, or they use all tricks of any kind. But it also includes those with kind of like the New England Journal of Medicine, the deniers, those with allergies to everything. Yes, indeed. That's patient two. And patient three is where those two extremes meet. So I've just really purified the form. Everyone's a little bit of a compilation of these, a little bit, but you can certainly identify those in category one. You can certainly identify those in category two. And then there's category three when the two extremes meet. That is, you have a challenging personality and has problems that no one knows what to do about. And if they step into your room, you have a problem. You've got a problem there. If you want to manage it, it's a challenging situation. We can relate to lots of people. The effects of challenging patients on the doctor, all those things can occur. Some patients, and this could be the doctor's fault, doesn't really matter whose fault it is, but some patients get under the doctor's skin and can really affect the doctor's well-being and affect their view of medicine, can affect the view of how they practice medicine. And for some doctors known to me personally, they've left the profession. They've left general practice, rather. They've left general practice because, and when you drill it down, they might say it's because of stress, but when you drill it down, it's because of some of these people who are so exhausting. Okay, so for the rest of the talk here, I'm going to use the RSUGP roles of the GP supervisor, the 10 roles of the GP supervisor, as a general advice to give to registrars as opposed to specific advice. It's very helpful to be an information provider and to discuss about different personalities, personality disorders, and the different approaches that we can have with each of these types of personalities, similar to what the New England Journal of Medicine was talking about. So, for example, someone with a borderline personality, of all the personality disorders that come to general practice, 50% of personality disorders are borderlines and in general practice. And that stands to reason because borderlines crave a special relationship that's just you and them against the world. But the special relationship is such that really you kind of have to do what they say. And if you don't, then suddenly everything turns and you're now the worst doctor in the world. For example, I would say to my registrars, I'd use these examples like I'd actually role play the patient and say, Dr. Tim, you're the most beautiful doctor I've ever met. You just saw right through me. This is the best day that's ever happened. I can't believe it. I can't believe I'm here and you've just said everything for me. This is great. I'm just so grateful. It's just great. Thank you. I don't mind paying. I'll pay $100. I mean, he's not. I mean, you're not like Dr. Simon. He's a bit strict, don't you think? So I tell that to registrars that borderlines love to split, and they'll do it in such a way that they will get the junior doctor, get you, to say things that you wouldn't otherwise say in the most subtle way. So let's just say that I was listening to that and say, I said about Simon, oh, yeah, he's a bit strict. Cool. Suddenly that's gotcha. There's a real connection. That's exactly what the borderlines want you to do. So I had one patient, she was pretty extreme borderline, and I'm not telling a lie. She saw me regularly, and every single time she said to me something like this. Oh, I said, oh, you went to the emergency department. I said, oh, yeah. Oh, yeah. They were not happy with your treatment. They were disgusted. Disgusted. Yeah, but I said, no, no. He's a good doctor. He's trying his best. Thanks, Joan. Really appreciate it. Oh, my dad, he's not happy with you. Not at all. Because he was trying to make an appointment and he couldn't get in. He couldn't get in. But I said, no, Dad. Dad, he's trying his best. He's busy. Thanks, Joan. Oh, Dr. Rang. I went to see him. And he was very unhappy with what you were doing. And I could, by this stage, anyway, long story. But that, I'm sure some of you can recognize all that. Then it's classical splitting. So it means that I would think, oh, Joan, thank you for that. I really appreciate that. We're friends, aren't we? Thanks for supporting me. In actual fact, it makes you feel quite uncomfortable. And Joan's, she's passed away now. I grew to really love her. I grew to love her as a patient, but it wasn't easy. It wasn't easy, particularly for the first 10 years. So it's helpful to talk about personality disorders with registrars, and it gives them a kind of basis.
I'm thinking two things, Tim. One, I must recruit you for a role play video. But second, we probably should try to convert some of this into a teaching plan, because it might be a very useful structure for supervisors to talk to registrars, or indeed registrars just to read around it anyway, about in terms of the information provision that you've talked about, and how these types of personality disorders may present.
Sure. Yeah, well, I think that would be helpful. So then I want to talk about being an advocate. Okay, so this is when, more than any other time, the registrar needs your advocacy. Just monitoring how many highly challenging patients they're seeing. I urge you to all do it, just to keep a tabs on it. Not to be too intense about it, but we all know some of the kind of difficult patients. A lot of challenging patients will gravitate towards the junior doctor. And that certainly happens with all the registrars that I have. I always want to keep a monitor of what's going on and seeing who's coming in and what's happening, and to be an advocate for them, to support them. What can happen is that other doctors at the practice can offload their challenging patients for a while. They can say, phew, fresh meat is coming to the practice. We can throw these hyenas to that doctor over there for a bit of feeding, just to give me a break.
Curious to know whether people do know, have a good sense that their registrar isn't overburdened with these types of patients. I would like to think most do, but I think your point's a very good one, Tim.
I don't think you can say for sure, but you do have a good idea of what's happening.
Yeah.
At least I do. Doctors can offload other patients at the practice. That's certainly happened to me at a practice. I had one doctor, again, all these people I mentioned have actually passed on, so I feel a bit comfortable mentioning them all, but I was a senior doctor, and this is going back about 30 years now, but he said, he was an English fellow, and he said, yes, Tim, there's actually, there's somebody that I'd really like you to meet. She's a bit different. She's a bit different, but I'm sure you will do. You're the perfect person for her. You can manage her. Now she's having headaches, and occasionally comes in for pethidine injections. And while we were speaking, I tell you no lies, she came into the practice, and and the doctor saw that and quickly ducked down behind the receptionist's desk. And I looked down at him, and he looked up at me and said, "Did you see me?" And I said, "Yes, she did." And she came over and said, "Hello, doctor, what are you doing down there?" He looked up at it and stood up and said, "Oh, hello, this is the young doctor who's going to take over your care." That was another 25 years until she passed away from paracetamol overdose. So that does happen. Doctors hand over patients to junior doctors. And just watch it for yourself. There's a great temptation. We've got one guy. Look, this talk makes it sound like all my patients are terrible. 99% of them are beautiful. But I've got one guy, he has a gift of making people angry. It's amazing. 10 seconds. I can guarantee he'll make every one of you angry. We have the most delightful and experienced and benign receptionist staff, and half of them won't talk to this fella. So he is challenging. But he ended up wanting to see another doctor. And I first thought, you beauty, fantastic, great. But then later on, I recanted and I thought, no, he's mine, he's all mine, and asked him to come back and see me. I'm just mentioning that story because there is a temptation to actually have a rest from some of these people. So retrieve the challenging patients back to your own list. They do wander. They do like to check out the junior doctor and have a crack, see what they can get. But I always try and gravitate people back if possible. As a reflector, it's really helpful to just discuss things with the registrars, and I know most of you do. I would have urged you to avoid comments that diminish the concern about the registrar. Like, just forget it. Don't worry about it. Don't worry about it at all. It's the problem's with them, not you. It's not you. You're great. It's just them. They're nuts. They're nutter. That sort of comments, though it can kind of build a registrar up a little bit, it doesn't offer much solutions, and it tends to diminish the anxiety and the concern about it. I think having a chat to them is very helpful. Having an extended chat about possible solutions and which way you can go with them can be really helpful. Being a reflector, I think also there's a need to acknowledge that it isn't easy, and it's helpful for the registrar to know that you go home sometimes and require a scotch or a hot bath with some salts or something like that, just to, after seeing the patient, just to recover. It's very helpful for registrars to know that patients can get under your skin as the supervisor. It can seem like my first experience with challenging patients was in Dampier, and I saw the doctor then, wonderful, wonderful doctor, and everything he did seemed seamless. It seemed beautiful. It was extraordinary. I felt like nothing could get under his skin. He seemed to manage things so well. You can get that feeling that there's something wrong with me, or can I aspire to that? Can I get to that level? Is that possible, or do I have to wait 35 years to get there? So reflecting on that is really helpful. Insight to what's going on with the personality types we've discussed about already, and possible different approaches that can have an advice as to a way forward. I think it's really helpful to talk about, for instance, those with borderlines, to say to never, I often got told this, but not really in the context of patients in a GP setting, never to criticize your colleagues. So in that kind of splitting area, it can be very helpful to bring that up in the registrar before they even start. Very helpful indeed. Very important. So back to Clyde. Clyde opened up a whole new world for me as a very effective tool on how to deal with challenging patients. Because in the hospital, this is not a criticism of hospital care, it's just not their gig, and it's more our gig. And when I came from hospital, to see Clyde in action and to see what language he used and what he said and how he said it was possibly the best learning I ever did, just watching him in action. It cut through 1,000 seminars like this one. I just got a lot from him. Not just him, but lots of other doctors. You can watch them in action and think, as some registrars have said to me, are you allowed to say that? Are you allowed to do that? When they ask that question, they're still in kind of hospital mode, because in general practice, a lot more things are on the table. We can say a lot more things. And it was an eye-opener to me that there was a lot more options available to me. So being a demonstrator.
Can I ask you, how did that play out, and how would you recommend that happen? How did that happen? Did they say, Mr. Smith's coming along next Wednesday, I want you to come in with me and just observe my interaction with him, or was it engineered in that sort of way?
Nothing was engineered back then. It was me. Principally, I got myself into trouble with, when I say trouble, it wasn't kind of anything kind of medical negligence, but just painted myself into a corner, as we often do as registrars or even doctors. And at the time, thought it was an insolvable situation. I could see no way out. It was really involving someone just with anxiety who didn't recognize it anxiety. And when I mentioned that it might be anxiety, completely rejected that diagnosis and said it had to be, it was definitely something else, which I pursued. I went down that path. Nothing was coming up. And I'd kind of been persuaded by the patient that it wasn't anxiety. And so it became a bit of a mess. And so Clyde came in and basically demonstrated to me listening to the patient. He was very good at listening and acknowledging their distress, acknowledging that it's been a hard road for them, which it had been. I don't want to diminish the patient's concern. They weren't a malingerer by any stretch of the imagination. And then expressed what he thought was going on in completely different terms to what anything else I'd been explained to in the hospital system. So he said, what's going on here is that you have too much adrenaline on board. And that's going round. Started to talk about all the symptoms that's causing it. And towards the end of it, she was kind of eating out of his hand, so to speak. He demonstrated, she was saying, yes, 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 yes. I have all these things, glancing at me as if saying, see, learn from this guy. And I was learning, but I was learning, but in a completely different way to what she was thinking. And then he said, with too much adrenaline on board, there's a whole lot of things that need to be done. So he addressed, it was very holistic. He addressed her life, what was going on in her life. He addressed the lack of way too much stress in her life. He addressed the possibility of medication, of having holidays, all those things. I don't want to go into too much into it, but you've asked how, and I was witness to that. But initially came in as a kind of me plaintively squeaking, I don't quite know what to do, and the patient angry at nothing's being done when I felt like I've done everything I possibly could. I'm empty. Demonstrated to me that you're not empty. This is not a difficult person. You've created this, but it's not your fault. But he showed me there's many, many ways that you can deal with it. And he showed me his way of dealing with it, which was liberating as a journey. It was really liberating. I suddenly thought, there's a whole lot of other stuff that I could explain in different ways. And I don't have to be anchored to a set way of doing things.
Yep.
I could explain things in one way to this person, and I could explain it to a different way for this person and tailor make my explanations to the individual rather than saying the same thing.
I think that notion of joint consultations, part joint consultations, registrars sitting in observing, or even a three-way consultation can be incredibly powerful tools. There's talk of Berlin type debriefs and either formal Berlin style groups or just debriefing. I'd certainly recall as a supervisor in Darwin having three-way encounters with some of these types of patients and attempting to model discussion of boundaries and best practice in terms of managing some of these patients. Problem case analysis, random case analysis, and the value of role play, and I'm always keen to encourage that even if it's brief. The old shades of grey cards that many of you will have kicking around the practice have now become a digital version as the scenario app, and they contain difficult consultations, many of which are patients that are challenging. So they're good scenarios to talk through. And I guess I really like stories, and Tim, you've demonstrated that really nicely by sharing stories. And I think those sort of war stories and experiential discourse around how you've fallen in a hole or painted yourself into a corner or had a successful outcome with patients can be very powerful teaching with registrars.
For sure, yeah. It certainly was for me. And also made, I think when you get a little bit more grips to manage, once you get a handle on it, if I could put it that way, it makes the role of general practice very enjoyable, very rewarding. To me, almost the best part of the job. Because just occasionally, I'm not saying it happens all the time, but occasionally you get real breakthroughs, real joy, and a love for those people. And not having the heart sink of thinking, oh, really, so-and-so's booked in again. So that's at the heart of what I'd love to encourage people to embrace it rather than kind of run away from it. My dear dad was a doctor, and he used to say that regularly to me. He was a wonderful man, but he used to say that regularly to me, what a tremendous privilege it is to be a doctor and to have patients open up to you and often tell you things they sometimes wouldn't even tell their own spouse. It's a great privilege.
At a GP conference, RSGP conference in Hobart many years ago, Richard Flanagan was the keynote speaker, the author from Tasmania, and he stood in front of a group of GPs and said, "I'm so envious of you guys being able to hear people's stories all day as an author. And that's just an extraordinary privilege that I would love to have." So you're right. I think that's a really nice sentiment, I think, to reflect on as we're kind of finishing up.
Yeah, fascinating, because if I could just add on that with Richard, I mean, I think he's absolutely right, but it's a classic non-doctor's view as well, that thinking of all the benefits of being a doctor and not really acknowledging that can be also very exacting and very stressful. So how many of us have heard people say, if I was a doctor, I'd do this. If I was a doctor, I view it as a real privilege. It is a privilege. Don't get me wrong, it is a privilege. But that quote does imply not acknowledging the challenge it can be.
Wow, Tim, you've elicited some really wonderful, pithy kind of comments here. I like the concept of a challenging patient ceasing to be challenging once we find the right language to communicate with them. And I think that's so true. And that satisfaction about communicating with people about themselves and their stories rather than their illness, and how medical students can find that so rewarding. And yeah, that notion that challenging patients may, it is an interaction. It's between the doctor and the patient, and it may not be the same for everyone. A plug for our community platform. For those of you who are not on it, feel free to join up. We recognise these things take a bit of time to gain momentum, so we're always very keen for people to sign on through the website and start their own conversations.
Someone talking about doctors some doctors have Teflon, like no challenging patients come to them and some kind of attract them. Some are naturally very good at dealing with some situations. Challenging patients, they are people with issues and they need someone to sort them out. So some doctors aren't the sort of doctors to sort out issues. Some are not. We know this is super complex, this thing. I was going to say, actually, that's why some of the literature is not that helpful, because this is a very complex area. It involves the personality of the doctor and the personality of the patient, and it's something very individualistic that occurs in the consultation, that only generic advice can be helpful.
Well, Tim, thank you very much.
Thank you.
All the very best.
Thanks for watching. We'd love your feedback. Please comment or subscribe to our YouTube channel for updates on new videos. If you'd like to ask a question or suggest a topic, you can contact us via our website at gpsa.org.au. GP Supervision Australia is supported by funding from the Australian Government under the Australian General Practice Training Program.